Thanks for coming on this Saturday afternoon, this last symposium sessions of the day. My name is Diana Weil. I'm with the World Health Organization Global TB Program. I work on policy strategy, and I am not a modeler. But I'm a consumer, I hope, of the conclusions of modeling. And we're very pleased to have this session, I think, for all of us this year, particularly given I think one of the major themes of the entire conference has been around better use of data and better generation of data. And I think power of modeling came up from the beginning of the week at the Global TB Symposium and is really one of the key drivers now for generating some of the answers for some of the key questions we have. So we're very thankful to Richard White for organizing as coordinator of this session. And we'll have him speak in a minute about the background to some of the work that's being presented here. I just want to reinforce that we have three areas which are really critical that are being addressed broadly. Questions of measuring or modeling on health impact, on modeling cost effectiveness, and then modeling on cost and resource implications and prioritization. And we all know that with our new strategy and with the global plan and the aspirations that these really high aspirations they have, we really need to be extremely strong in our orientation toward prioritization. So we're excited to be introducing people here today. I'm here with Professor Ted Cohen from Yale University, who's also deeply involved in a range of TB research that's essential to the issues being addressed here today. So I think I'm going to have Ted introduce the first speakers, but we'll have Richard come up first and give a couple of minutes, very quick.
Thanks, Dinah and Ted, for the chance to speak about the consortium itself. I'd like to start by asking you to imagine a small child, a little child, bright-eyed, big smiles, very, very cute, but very dependent on other people, and ultimately pretty harmless. That, for me, was TB Mac about 4 years ago, when the foundation gave the money to start us off. Now imagine that little child growing up into a teenager, bit spotty, bit awkward, gangly. You can imagine it, couldn't you? But gaining a bit more confidence, making friends, making networks, very enthusiastic to this new world, and starting to express its own opinions. People start noticing this teenager, some welcoming the new ideas and certainly the enthusiasm the teenager brings to the world, but some really not quite sure about this new kid on the block. What are they up to? So along the way, the teenager gets into the odd scuffle. For me, that's been TB Mac over the last couple of years. Started to get noticed by the key stakeholders, started to be useful to those key stakeholders and decision makers, and noticing itself that those key stakeholders have very different agendas, very different ideas about what TB Mac should be and what TB Mac should be getting on with. I'm happy to say that teenager made it through those scuffles. It benefited a great deal from the interactions with stakeholders, and that TB Mac now has a new mandate and multi-stakeholder buy-in, and importantly, funding from the foundation for another 3 years. Thanks to that funding from the foundation, over the next 3 years, TB Mac is fully focused on increasing the effectiveness and efficiency of TB control at country and global level, and we're going to do that in 3 ways. First, we're going to allow or enable economists and modelers and decision makers to get in touch with each other, communicate and work together. Second, we're going to support the modeling community to allow modelers to create those essential new models and allow those models to be communicated and made accessible to decision makers. And third, TB decision makers are going to be enabled to use these models. It's not good enough just to give a model to a policymaker. You need to be able to train and to encourage and to educate about how these things can be used. As Stephen Lewis and others said much better than me, The challenge we face in defeating TB is truly daunting. With a new WHO strategy, the global plan, it's truly a critical time, and modelling has never been more needed and indeed more central to that task. If you're interested in getting involved in TBMAC, or interested indeed, we have a 3-year job available coming up in the Secretariat, please get in touch with me, Ted, or any other committee members who are in the audience, or just join up at tbmac.org. Now, enough about TBMAC. Let's get on with the interesting stuff of the day and see some of the things that TBMAC's been funding over the last couple of years. Thank you.
Great. Thank you, Richard. So it's a pleasure to introduce Achilles Katambo, who's going to be our first speaker of the day. Achilles is a university lecturer at Makerere University in Uganda. He's both a clinician and epidemiologist who is trained at numerous institutions and collaborates with a number of universities, including UCSF and Yale. Thank you. Just a word about timing. The speakers have approximately 10 to 12 minutes to speak. I'm going to stand up after 10 minutes, not to cause any kerfluffle, but just to give you a sense of what your timing is, and that's going to assure that we have some time left over for questions.
Yeah, thank you very much. Good afternoon to you all. I'm presenting on this on behalf of the members you see there, who are the members of TBMAC. And this is a cost effectiveness of chest X-ray for facility-based screening of TB among adults in Uganda. Yeah, that's the outline of my presentation. So just a quick introduction and go through those various components. And as an introduction, TB in 2015 was really identified as the #1 killer disease among the infectious diseases. And we know that a third of the TB cases are missed. Most of the people who come, even on passive case, they just bring themselves within our care facilities. We end up missing them, really not detecting them. But it has already been shown that systematic screening of these patients who come to the clinic actually could yield a lot, and we reduce the number of cases that we are missing. And what should we do in order to find these ones? And this is the gist of these presentations, really, to try to make sure that we increase the number through active case, through screening. And in order to do that, the team you saw there conducted a cost effectiveness analysis and to try to look at how do we screen within healthcare facilities in Uganda, and what would be the yield for that if it is to be put as one of the strategies to control TB. As you may be, some of you are aware of cost effectiveness, really it is trying to look at incremental cost effectiveness. What do we gain for any extra dollar? For example, if you have 2 TB tests, GeneXpert and smear as an example. When you look at these 2 tests, GeneXpert is more expensive, smear is cheaper. There is a cost for that. However, in terms of effectiveness, if you take it literally as number of cases detected, GeneXpert will give you more. So what is the additional cost for any additional case? But that could be measured also in terms of DALYs, queries, and other measures. So when you look at the chest X-ray in particular, the chest X-ray is a very highly sensitive test that has been used and found. Very cheap in a way. In Uganda, it costs about $3. And it has low specificity. And so using it as a triage test really would be a very good advantage to try to look at those people who come in the clinic. But in a way, as we talk of facility-based systematic screening of tuberculosis, there are many people who come in the outpatient clinic on a daily basis. And there may be some of those who come with symptoms of cough for 2 weeks as defined by WHO and other experts, but many of them don't end up being tested. So if we screened everyone who came, we shall be able to identify some few people. Syria is similar to someone who has come in a clinic and probably has come for other, and you decide that we shall do a routine test for just, let's screen for high blood pressure in patients who come in the OPD. So in a chest X-ray, in this case, we are taking it more as a screening test, not really as a diagnostic test in this. So when you go further, the method to do this in terms of method, it was a decision analysis model using Markov modeling. In a way, these Markov models, the pointer seems not to work, probably. Yeah, so it used the Markov modeling, and in a way, you make a decision whether to put a patient on a triage test, or you make a decision to follow what is going on in the standard of care where we are not doing triage testing. And people could follow in any of those Markov states, and people could move back and forth from one state to the other, in that you can be in one state, but then you can move into another like that. And then we can see that there are many different parameters that will affect the performance of that test. These parameters include probabilities. Really, when you decide to test someone, the probability, whether it's positive or negative, that's based on either some previous studies, looking through literature and getting those figures. And also we are looking at these different diagnostics. What's the cost of each of those different diagnostics? As I told you earlier, expert may be more expensive than smear and other tests, and the effectiveness depending on how we look at those. So those will affect this model. And so if you look at the probabilities, so in terms of probabilities, you may find that if you use the triage test, maybe 5% of those people who come in the OPD have active TB, and 95% do not have. So there is a cost you've incurred there by actually doing that test. And then, depending, then some may have HIV, others may not have HIV. And then, in terms of diagnostic performance, you may find that for those who are known HIV positive, the test may be 89% people may be positive who have TB using expert, and maybe 11% may be negative. But there is a cost, which is like for expert, $24, but if you don't do the test, maybe it is $0. And that test can vary, as we shall see in the sensitivity analysis. The effectiveness may be whether people cured, died, and that was the measure that may be looked at, but there are many others which may be looked at. So what was found in this study? It was found that if you used a chest X-ray as a triage test versus the standard we are doing where we are not doing it, it would cost $610 per year of life gained. And that could range based on a sensitivity analysis from 200 to 1,800 per year of life gained. And that's based on the model assumptions. A sensitivity analysis was done, and this is really trying to give us the gist of how this test would perform in different settings in the area. And so looking at the parameters on the x-axis here, on the y-axis, you can see the parameters: prevalence of active TB, probability of death, cost of chest X-ray, and that's the sensitivity of clinical diagnosis. Looking at those three parameters and testing them out in different settings. And the black line there is like the $6 and $10. So it shows you the incremental cost effectiveness, how it would vary in different settings as you look at those parameters. So assuming the triage test is just cost $1, if the triage test is costing $1 in a setting, it would be very applicable if you had in a prevalence setting of about 4%, such a test And if you compare it to the standard of care, if you look at the curve, it shows you that the probability of death is actually low if you use that in that. So in a setting where you can afford that, that's the impact you do have. But in a setting where, like in Uganda, where X-ray is about $3, referring to X-ray, this is the impact of triage testing in terms of monthly probability of death of untreated TB versus also the prevalence. So the prevalence, if you look at in a setting where it's about $5, then looking at also the prevalence of disease in that setting and the monthly probability of death for untreated TB. So the prevalence of TB in a setting has got a very important impact as far as what test to employ and what would be the impact of real triage testing. The higher it is, the better the impact of a triage testing. And this is where a setting where you could afford a $10 X-ray. And if you put these results into perspective, that's what it would mean. What are the limitations of this work? So it is really isolated on TB diagnosis and treatment. We very well know that we are looking at TB, but remember, 48% of the patients in such settings also have HIV. And so that's a limitation, may need to look at it more into that perspective. Future transmission prevented for unaccounted for. So if a test works well, like a triage test, and it prevents those transmissions occurring, probably its impact would be even much more than what we see now. So this is probably an underestimate of the impact of that test. Here also cost effectiveness was looked at an international sort of standard in that really GDP versus per capita, it does not put into considerations issues like what are other priority interventions within the setting and others. We used the year of life gained instead of disability adjusted life years, as WHO and other bodies. The World Bank report, Global Burden of Disease, looks at more of that. So its implication, cost-effective, chest X-ray is highly cost-effective for TB screening. You can extrapolate to similar settings as we looked at that. It's a matter of plugging in some of the prevalence and the costs and other things, then look at what would be the impact. If scaled up, can help detect much more of that 3 million cases which are not being detected. There's more research need to focus even on better triage tests. So just to thank those colleagues who helped put together also the presentation and the work. Thank you very much.
Thanks, Achilles. We have time for a couple of questions. I'd ask you come up to a microphone and introduce yourself. We'll also have a little bit of time at the end for general discussion, but now would be a great time for individual questions. Yeah, great.
Hi, Armina from the Netherlands. Just a quick clarification in your model. I see that the one that goes into the Markov loop is the one with the false negative, right? So with active TB, but it's not detected, they go to the Markov loop, but you don't really present the Markov loop. What happened afterwards? Do they get re-diagnosed or natural cure, or like what is your assumption in that Markov loop? Thank you.
Yeah, the people who don't get diagnosed, you assume maybe within okay. I beg your pardon? The people who don't get diagnosed?
Right. The question was about the false negative. What happens to the individuals who do have TB, but you don't pick them up with the testing? Do they have another
in the
chance
standard of care?
No, I think it was under the triage test. Do they have another opportunity to be diagnosed, or are they really lost to the system? Is that, yeah.
Yeah, the assumption is that if they get lost into the system and they are not diagnosed, maybe after some time they might come back. Most so if someone had TB, you would think that his condition would worsen and over time he would come back. And so the assumption that they may come back to the clinic maybe after some time. Yeah.
You wanted to do a follow-up?
Sure.
Yeah, but do you do also a sensitive analysis in that assumption? Because I do a similar thing and I got a big criticism on that because they say it's a very bold assumption to assume that people will go back and everything like this. So do you do a sensitivity analysis on that?
Okay, maybe I would call on the actual person. I didn't do this analysis in particular. As you saw, I'm presenting it on behalf of my colleagues. So I don't know whether they did that in particular to look at the sensitivity analysis for those. Yeah. But as I said, there are limitations in that, in a way, even in the transmission per se, people who may be transmitted. So those assumptions you need to consult.
Right. So I think this is a great venue to make these connections to see what other people are doing similar work. So I'd encourage you to continue talking because these details make a big difference. So that's great.
Just one comment from our side. I just want to say that WHO is just shortly, in a matter of weeks, is going to reissue an updated fact sheet on the role of X-ray for screening and diagnosis, basically revisiting what our current guidance says across screening and diagnosis. So in one place you can see what currently do we have guidance on the use of X-ray, given its increasing documentation of value, but a lot of confusion over its use. And that we're also issuing operational guidance, because one of the big questions in this is who does the X-ray exam, what's the quality of that X-ray exam, and administratively it's obviously a challenge in some settings to get this to work. And so that, I guess, would be interesting. We can come back in the discussion at the end about what were the administrative costs that were built into that model. So we can maybe do that at the end.
Yeah, and maybe one thing that probably also, if you look at people who come with cough for 2 weeks and use that as a criteria for screening, there is a number of people you may be missing out. Maybe as much as a patient population, but we see that in the prevalence survey, for example, which has just ended in Uganda, we see that out of the 160 TB cases bacteriologically confirmed, 148 had abnormal chest X-ray. And among the 66 patients who were smear positive, only 45% of them actually never had cough. So you could see that even within the analysis, because it was focusing on people who have cough, there may be also many people within that outpatient who may be missed out, though. So as we think of the chest X-ray as a triage test, is it for only those who have cough? Because cough as a symptom seems to be quite limited in detecting, but this was more of a population-based study, probably not necessarily reflecting clinical-based study.
Thank you, Achilles.
Yeah.
Great. So it's a pleasure to introduce the next speaker, Dr. Amber Kunkel, who is from Harvard School of Public Health and Yale School of Public Health.
All right, thanks, Ted. Thank you, everybody, for coming to listen today. I'm excited to be presenting to you some of the work that I've been doing modeling trade-offs in new TB drug introduction policies. And specifically, I'm going to be talking about the new drug Bedaquiline, which is quite an interesting case based on the limited trial data that we have available showing this promising efficacy data, but also this concerning and unexplained increase in deaths in the bedaquiline-containing group in its pivotal phase 2b trial. even if we were to ignore the safety concerns, we'd have several questions about how we should best be using bedaquiline and which patients should be receiving this drug. And these questions relate to how we can use bedaquiline to prevent resistance to bedaquiline, but also how we can use bedaquiline to protect some of the other drugs against resistance, and then also what the potential impacts are on transmission of TB in general and especially of resistance. The current guidelines recommend that bedaquiline may be used for patients who have MDR-TB with additional resistance or intolerance, but most of the thinking and discussion here has been around individual patient safety and also some of the operational issues and how we can be using bedaquiline. What's not been done so far is coming up with a clear way that we can link some of these population-level concerns about resistance and transmission to policies and decisions about which patients should be receiving bedaquiline. Certainly this is something people are thinking about, but the connection is not entirely clear, besides this often repeated refrain never to add a single drug to a failing regimen. So we attempted to fill in this gap with our model that was looking at different policies of providing bedaquiline to either all patients with MDR-TB, patients with pre-XDR or XDR-TB, or patients with XDR-TB only. And we looked at these different policies in terms of outcomes of mortality, resistance, and then also the number and the outcomes of secondary cases. We built a Markov cohort model that focused on patients initiating treatment for MDR-TB and also their immediate contacts. To define the background mortality rates in this model, we assumed that the people we were interested in were HIV-negative European men who were 30 years old at baseline and also sensitive to bedaquiline at baseline, but who had a combination of either MDR, pre-XDR, or XDR-TB. And we classified these individuals into mutually exclusive states based on their culture status, the risk of relapse, the regimen they were receiving, and also their resistance pattern. So these hypothetical patients could then transition between these states, we assumed on a weekly basis, based on some events that they could experience, such as converting their culture or acquiring resistance or dying. And we inform the probabilities with which patients experience these events based on cohorts and trials of MDR-TB. And specifically for the bedaquiline-related parameters, we focused on the C208 and C209 trials of bedaquiline, as well as some of the data that was starting to become available from interim cohorts of compassionate use programs. But there is still very limited data on bedaquiline use, so for all of the bedaquiline-related parameters, we allowed them to vary within fairly wide ranges. So all of the results that I'll be presenting to you are based on ranges of these parameters. This slide shows the primary results, so just to orient you for a minute, I don't know if I have a pointer here, I don't think so. So the left column here is showing what our different policies are. So on the top, it's showing not allowing any patients to receive bedaquiline, and then below that is, thank you. So here, this is no patients are receiving bedaquiline. This is only patients with XDR-TB, and then with pre-XDR and XDR-TB, and then finally making bedaquiline available to all patients. And then each of these different columns are showing different outcomes that we were interested in. So this first column here, this is showing our life expectancy outcome. There's a couple interesting things to note. I think the main things I would focus on are noticing that for most of the assumptions that we were making about the different values of these parameters, we found that the optimal strategy in terms of maximizing life expectancy would be either to give bedaquiline to all patients with MDR-TB, that's this one here, or it would be to withhold it from all patients. So not letting anyone receive bedaquiline. And so this was based on our assumptions in terms of mortality, where that bedaquiline has some efficacy in terms of reducing the time to culture conversion, and that also reduces the TB-related mortality, but that there also might be some added mortality associated with use of this drug. I think that the particular balance between this most liberal strategy of letting all patients receive bedaquiline versus not letting any is less important because the particular parameters there were not entirely clear, which is why we're exploring this range. But what I think is really interesting here is that very rarely are we recommending these intermediate strategies of providing bedaquiline either to patients with XDR or pre-XDR TB. It seems from our simulations like it's most likely that we should either be giving bedaquiline to everybody or not using it at all, as long as we're focusing on life expectancy. Moving on to resistance, this should be pretty intuitive. So if we were interested in just reducing the number of patients who develop XDR TB, we would always prefer the most liberal strategy of giving bedaquiline to all patients with MDR TB. And also, trivially, if we wanted to prevent resistance to bedaquiline, the best thing to do would be not to use bedaquiline at all. And that's also the case when we look at this combined XDR with bedaquiline resistance outcome. But obviously, if we're not using the drug at all, then preventing resistance to it is not such an important thing. And then, interestingly, I think if we look at the outcomes among our secondary cases, the best strategy in terms of reducing the number of secondary cases was always to give bedaquiline to all patients with MDR. And in all but one scenario, it was also the best strategy in terms of preventing the number of life years lost to our secondary cases. I'm going to talk a little bit more about this life expectancy outcome, since this was one where the optimal strategy was not entirely clear. If you look at this top figure here, the main parameters that are influencing this outcome are parameters on bedaquiline efficacy, how it's affecting time to culture conversion, and also the safety of bedaquiline, so what additional mortality is associated with that. And the other parameters that we explored, such as the effects of bedaquiline on resistance, were much less important. And then on these bottom graphs, you can see that the way this plays out is sort of what we would expect, so that in general, if bedaquiline is more effective and it has less impact on mortality, then we'd prefer to use it widely. Whereas if it's less effective and it has a greater harm, then we would prefer not to use it at all. And again, I would point out that there's only this like very narrow strip here where we're preferring the intermediate strategies. So this is the same as the slide that I showed before, except that it's excluding the no bedaquiline outcome. And the results are all very similar, except in one case, and that's our combined XDR and bedaquiline resistance outcome. And when we look at this outcome and we assume that at least some patients are receiving bedaquiline, most frequently we prefer this intermediate strategy where patients who have pre-XDR or XDR TB are eligible to receive bedaquiline. So some conclusions. I think it's important to note that a model is not going to tell us whether bedaquiline is safe or not. And really, we're going to need more data, and I think especially phase 3 trials, to make sure that there is really a mortality benefit to bedaquiline at the individual level. But this is perhaps more helpful in thinking through some of these other outcomes, and the results are probably intuitive when you think about them. So more liberal bedaquiline use strategies would lead to greater resistance to bedaquiline, but also less resistance to the other drugs. And the exception to this would be when we look at that combined outcome of XDR plus bedaquiline resistance, the intermediate strategy seems to be the best outcome, but in this case, the effect sizes are very small. And also, more widespread bedaquiline use would likely decrease transmission and extend the life expectancy of potential secondary cases, which is also something we want to keep in mind when considering how to use this drug. So I'd like to thank Ted Cohn and Frank Koblenz, who worked on this with me, as well as TB Mac for supporting this work.
Time for a couple of questions.
Hi, Ravendi Nathvatharana from Boston. Hi, Amber. I think it was a great talk. What I was wondering is whether you thought about clofazimine cross-resistance when you were thinking about resistance to bedaquiline. I think that there's probably little data on it, but and I think that there's not a lot of documented resistance to clofazimine. But was that something you could incorporate, especially as we use the short course regimen more and more globally?
Yeah, that's a great question, and it's something that we decided not to incorporate based on, like you said, the real limited data that's available. Where that comes into our model is, we've made this assumption that all of our patients are sensitive to bedaquiline at baseline, and that may not be the case if they've been exposed to clofazimine. My guess is that the numbers of people who are resistant to bedaquiline through that route are pretty small, but I'm not certain.
Thanks.
Stuart.
Institute of Disease Modeling. I had a question about your percentages, just kind of a basic question about your primary results. How should I interpret those percentages when you have an outcome of like 77% for MDR versus 20% for none? Is that based on the number of simulations, or is that somehow a confidence, or can you go into more about that metric?
Yep. So my apologies, I should have explained that a little bit more clearly. So these percentages that I was showing, these are based on, we ran, like 5,000 different simulations with different parameter sets, and then these are the percentages of the time that each of these strategies are optimal. So if we compare for each parameter set all of these different strategies, for instance, if we focus on this column here, then for 78% of the parameter sets that we explored, the best outcome was to give bedaquiline to all. The best strategy was to give bedaquiline to all patients with MDR-TB. We also looked at the magnitude of the differences, and I don't have those results right here, but for the most part, they were actually pretty small. So a lot of the time, the intervals were sort of overlapping, and it was less clear when we didn't sort it out by looking per parameter set.
But that doesn't necessarily translate to a human population. I'm saying like 78% of individuals. It's just saying 78% of your distribution.
Correct.
Thank you, Amber. Oh.
So we'll have more questions at the end. So we're obviously addressing a range of questions here today. So we're jumping from a few really critical issues, and I think we have to remind ourselves again that this is cutting edge, particularly in this case because this is a phase 2b drug with interim guidance, and so really it's a really exciting time to be getting data as we're looking to getting clinical trial information in the next 2 years, and then we'll have a very different picture of discussions around our revision of overall guidance. So it's exciting content. In school, she's a social epidemiologist who's been working and passionately advocating for more research around TB and social protection, both for prevention and response, given disease in families and communities. I think she's going to introduce to us first what Expectancy is, which is a grant program that was, a grant that was given for a new area of work under TB MAC, which is exciting, and a little bit of some of the work coming out.
Thank you. So thank you. Good afternoon to everyone. I'm delighted to introduce you to the Expectancy project on behalf of the Expectancy team. I'm sorry that some of the senior modelers that took part in this initiative are not here, but I'll do my best to represent them. Expectancy stands for Social Protection to Enhance the Tuberculosis Control. It's a very young project. It was funded by the Gates Foundation through TB MAC. In this presentation, I will use these 10 minutes to give you a flavor of what kind of research approach we took for this initiative, and I will introduce you some very preliminary results, which you will have to take as an example of what we did, how we did it, and what kind of challenges we met. But for those of you who are not familiar with social protection, just a little bit of background that will put your mind at rest after so many complicated and very intense presentations. So social protection is a very broad and vast container, including a number of poverty reduction strategies that are today largely implemented in low and middle income countries, and in fact even in high income countries, although in a different format. I think it is fair to say that perhaps the most common, or most popular, I should say, form of social protection are conditional cash transfer interventions. There are interventions in which cash is given to households living in extreme poverty with the purpose to move them out of extreme poverty, and could be given, this transfer can be given either unconditionally or conditionally on the assumptions that households have to meet some kind of behavioral requirements, like sending kids to school, having them checked in terms of nutrition and vaccination. There is a bulk of evidence, an increasing bulk of evidence about the potential public health impact and real public health impact of conditional cash transfers. And this is also one of the reasons why social protection and particularly conditional cash transfers are today considered one of the key elements of the new TB and TB strategies. However, it is also fair to say that despite the fact that evidence on the impact of cash transfers on TB are accumulating, these evidence are still very fragmented and I would say rather inconclusive. Mathematical modeling can do a lot to fill this knowledge gap because it would, it can save you to undertake very expensive, often very complicated and sometimes unethical impact evaluations. Nonetheless, it is true that no one, as far as we know, have tried to use mathematical modeling to try to estimate the impact of social protection and particularly cash transfers on TB up to now. And this is probably due to the fact that mathematical modeling in TB is mainly predominantly used for biomedical, to test biomedical interventions. It is true that some of the challenges that have hampered probably this effort are due to the fact that the classical compartmental models that we used in TB are probably too rigid to try to encompass the complexity of social and socioeconomic phenomenon. And this is also due to the fact that, in all honesty, it's not entirely true understood how cash transfer might have an impact on health outcomes and TB. This is itself is due to the fact that despite the production of conceptual frameworks that try to articulate this impact, this conceptual framework had never been validated by proper epidemiological studies, and there are not many data that can help us to populate these conceptual frameworks in a way that we confirm certain pathways. Ultimately, the main cause of this delay in using mathematical modeling for these efforts is due to the fact that until probably 12 months ago, we never had the chance as social epidemiologists and mathematical modelers, to gather together and try to find a solution to this. And Expectancy was in fact created to respond to these challenges by creating an interdisciplinary consortium made by social epidemiologists, mathematical modelers, policy implementers, and policymakers to strengthen our understanding of how social protection can enhance TB control through mathematical modeling. The specific objectives of the project were to develop a conceptual framework that could be translated into mathematical modeling terms, to create a publicly available data portal, and to develop an innovative mathematical approach that can encompass the complexity of social and socioeconomic phenomena. The key steps that we took over this first 12 months of life of the project were essentially the creation of the development of this conceptual framework and the translation into some sort of more mathematical modeling suitable type of framework, the prioritization of certain pathways, and the development of a model that could capture the effect of social protection. And for the purpose of this exercise, we used as a case study the Bolsa Família program in Brazil, which is the federal conditional cash transfer program in Brazil and one of the largest conditional cash transfer program in the world, with about 50 million people are now covered by the program. It is targeted to people living in extreme poverty with an average income between $35, $70 per month. And the cash benefits that people receive goes from 18 to 175 per month, depending on the household composition and how many children are in the household. Cash are given under 3 conditions. Women that receive the transfer have to be responsible of taking kids for and themselves to antenatal and postnatal care, have regular check for nutrition and vaccination checkups, and school attendance for children until the age of 16. So the way that people like me conceptualize the potential impact of social protection programs like Bolsa Familia on TB is in this way. We can, this conceptual framework, assume that, oh, sorry, I didn't meant to do this, but I have to do this probably. No. Anyway, so we can assume this. Yeah, but this way maybe. No. Okay. Yes. Thank you. So we can assume that. Okay. So we can assume the Bolsa Familia can have effect on TB directly if we assume to introduce some TB-specific conditionalities by which TB patients are meant to, complete their treatment in order to have the cash transfers, or maybe TB contacts have to go and be tested if they want to get the cash. Or indirectly, if we assume that cash transfers like Bolsa Familia can improve the household socioeconomic position of the household, can improve food security and food consumption, and this in turn will improve a number of more proximal determinants of TB, like crowding, biological risk factors like the likelihood of having HIV or having diabetes or having some drug or alcohol addiction, and also the household food security, but also the food consumption patterns. The effect of Bolsa Familia arrives it explicits itself on TB prevention and TB treatment or TB support, depending on which stage of the disease pathway is affected, and also what kind of population is affected. In this kind of framework that appears to be so complicated, you need to identify, we can at least identify 3 different levels of impacts. There is one impact that is at the level of Bolsa Familia on the distal social determinants of TB. The second level is the impact of the distal factors on the more proximal social determinants of TB. And the third level is the impact of proximal social determinants of TB on TB outcomes. And I'd like to draw your attention to these 3 levels because these are essential to understand the modeling strategies that we adopted later. When we showed this conceptual framework to the modelers, I wish I could show you the face of David Dowdy and Philip Eckhoff. They were just saying, no way, we're not going to model something like that. So the first step that we had to do is to massively simplify this conceptual framework and basically unpack this very complicated, that incidentally is also a very simplified version of what is likely to be the actual mechanism through which social protection act on health outcomes, but to unpack this very complicated version and extract a number of shorter and more simplified pathways in a way that could be suitable for modeling. This exercise of unpacking and extraction of pathway return a conceptual framework that is much more schematic, if you see, in which these pathways, and we extracted 13 different pathways, shorter pathways, can be enumerated and listed basically one next to each other. We tried to respect this levels kind of structure with the level 1, level 2, and level 3, but now the pathways were much more shortened and much more suitable for modeling purposes. We then tried to prioritize these pathways by looking at the public health relevance and the measurabilities, and in other words, whether or not we had the data. And this effort resulted in 3 pathways came as probably the most relevant for this first attempt to model social protection. For the purpose of this presentation, I will focus only on pathway number 10, which basically shows that Bolsa Familia has an impact on household socioeconomic position, which in turn has an effect on malnutrition at household level, which in turn can reduce a risk of reactivation and increase the chance of treatment success. And in the slides, you can see that each of these steps reflects the level 1, level 2, and level 3 structure of our framework. when we had the modelers started to think about how to model this pathway and all the other pathways, they came up with some sort of revised version of the classical compartmental TB transmission model, which was able to incorporate the level 3 estimates on a transmission model like this one. And in order to do that, we had to take 3 steps. In the first step, we had to estimate the level of impact on each level, and so the first one, which is level Bolsa Familia on household socioeconomic position. Level 2 is the effect of household socioeconomic position on nutrition, and level 3 is the effect of nutrition on the treatment outcomes. Once we had generated this level of estimates, 3 levels of estimates, through a very intensive search of the literature, we combined them into a combined estimate, and we included this in the transmission model. This is the results of the first part of the exercise with the estimate of impact at the 3 different levels. And there's no need for you to go through these numbers because I will come back later to this. And this is the effect of combining this estimate together and see how this estimate combined together could have an effect on the 3 TB outcome of interest that were TB diagnosis, TB treatment, and TB transmission, and how this effect on these 3 TB outcomes reflected and translated into the reduction of TB prevalence in the long term. The key findings on these slides is that apparently if we focus just on pathway number 10, the impact of Bolsa Familia on the long-term prevalence in Brazil, it seems to appear low, just about 4%. However, I'd like also to draw your attention to the fact that the range of estimates was very broad, which is a reflection of how, if you like, unstable were the estimates that we made. The apparent low estimate of impact of Bolsa Familia on TB prevalence was due to the very low estimates of the impact of Bolsa Familia on income and the very low impact of income on household nutrition status. I haven't put in these slides another results not to bombard you with numbers, but it's important for you to notice that in another exercise, when we skipped basically this level 1, level 2, and level 3 approach, and we went straight to the impact of Bolsa Familia on BMI, on the nutritional status of the household, the impact of Bolsa Familia on long-term TB prevalence was about 32%, so about 10 times higher than the estimate that we generated here. Yeah. So the kind of the number that I've studied, the estimate of impact that I've studied here are probably just an illustrative example of what we can do with the modeling of social protection, but I think that they are much more important to highlight some of the challenges that we face during this exercise. First of all, it is critical to understand what kind of study population we need to include in our analysis. It is important, it is essential in order to estimate the impact of social protection on TB that we are able to at least estimate the relative proportion of TB cases in the people who receive Bolsa Familia compared to the general population, and understand also the extent of mixing between these 2 groups. In the case of Expectancy, we assumed that there was no mixing, and we assumed also that the kind of perfect population for this type of study was the population that is targeted by Bolsa Familia, that are households living in extreme poverty. And we base this assumption on the fact that the people living in extreme poverty are the most likely, this group is the most likely to generate the highest number of cases, and by acting on this group, probably we can affect TB prevalence in the general population. However, more epidemiological studies are needed to understand, the questions that I raised before, and also to profile better TB patients that receive Bolsa Familia compared to non-TB patients that receive Bolsa Familia, and understand how if there are specificities that are likely to be picked up by Bolsa Familia. The kind of results that I've shown here are based on 13 different pathways and 1 specifically, but it's likely that not even these 13 pathways are likely to capture the the complexity of how social protection has an effect on TB. And most important, these 13 pathways are likely probably to have a very materialistic approach. You know, we look at household socioeconomic position, nutrition, housing conditions, but it's likely that we will have to move forward this materialistic approach and look at two other models like, you know, the psychosocial model or the life course approach. Most importantly, I think that you could appreciate that this approach looking at pathways and different levels is essential to understand the mechanism through which social protection happens. But at the same time, it could be that the more levels we introduce and the more diluted is the effect of the social protection on the final outcome, especially if the biggest of the impact happens at the bottom of the chain. Our problems were also due to the fact that a lot of the numbers that we had to put in these three different levels were very difficult to find. And in fact, I hope you didn't notice too much, but I deliberately skipped the generation of the data portal because of all the objectives of S Protect, was probably the most underestimated in terms of complexity. We realized that to generate the evidence, to populate this pathway is a tremendous effort, and to put them together in a way that are coherent is even more difficult. It's almost a standalone type of project. One of the major difficulties that we had as a social epidemiologists and modelers is to pick up data from different sources of the literature, from the development literature and TB literature, and convert these outcomes and unit of analysis in a way that it could fit into the same models, because sometimes that was not possible. So the modelers had to go through a number of conversions that were never validated, so we still don't know whether what we did was done appropriately. Yeah, to conclude, this was a fascinating task, but very difficult, although not impossible. Please don't go home thinking that the impact of Bolsa Familia on TB is 4%, because this was just an illustrative example, and more analysis is due. This was just an example of that, again, this is possible, and through S Protect we can achieve a better understanding of social protection, but more work is done, and we need to go forward and consolidate the existing work and explore other research questions. Thank you.
Using the metaphor of the child and the adolescent, I think this
is a
new field, and so we're dealing with a toddler who's exploring all over the place, a little bit uncontrolled but controlled, so we're trying to direct it in the right way. So it's an exciting field, and I have to say at WHO, given the Sustainable Development Goals and the linkages, there's a lot of interest in looking at how can we show where does health interventions as well as broader development interventions interact. So I think this is a really interesting field and a very difficult field, as you can see, to tease out. So can we have one question now, and then we'll have more questions at the end? Yeah, go ahead.
Thank you. Florian Marx from the Yale School of Public Health. First, thank you very much. This is a wonderful project, and I really also liked how you conceptualize the role of social protection and the impact on tuberculosis at the different stages of TB risk for prevention, also for seeking care. I want to bring one more aspect in, which is the role of employment. We know that the population, as a phenomenon of general poverty, unemployment plays a role in the population that gives rise to tuberculosis cases. But then also people lose their job at the time they suffer from tuberculosis. And I guess, and I haven't seen data, but it will be very difficult due to stigma after tuberculosis also to get into employment again. And I just wonder if we should focus, besides other forms of social protection, such as cash transfers, such as education, if we should also focus on initiatives such as training, short-term trainings, and provision of employment, whether we should focus on such interventions not only as a form of reducing poverty in terms of money for households, but also in terms of a structure for households to receive better care, to receive screening for all sorts of diseases, and to have a structure to reduce the risk of tuberculosis. Have you got any thoughts on that?
Yes, I think that the two levels. The first answer is that yes, social protection is a very broad range of activities and initiatives, and I think that we haven't even understood yet what might be the best form of protection that could fit better. It's likely that a combination of them, and it's likely that ideally we will reach a stage where TB patients are address to the best schemes and the best kind of form of social protection that can give them the best output. At the same time, I think that it's fair to say also that for modeling purpose and to understand the impact and the potential of this type of different strategies to address tuberculosis, cash transfer are those that offer the best in terms of data availability and impact, rigorous impact evaluation. So I think that as much that I agree with you with the fact that we are focusing too much on just one single strategy, which is not even likely to be the most successful. And I don't know if you were at the plenary this morning, but the guy who was working on Bolsa Familia emphasized a lot the fact to protect labor and employment in TB patients. But again, I think we will we'll have to reach a compromise between the need, a policy level answer and a more mathematical modeling answer that require data that at the moment are only provided by cash transfers.
Thanks so much. We have, I think we'll finish with this for now, thank you. Yeah. And then and we'll come back if there's any, we'll probably have time, and if people can stay over a few minutes, we'll have time for a few more questions at the end. Thanks so much. We're now experimenting with using slides that are loaded, but the audio of our speaker who could not be with us physically today. So first, the topic is illness-related impoverishment averted by TB control, findings for India and South Africa, two major countries where there's been a lot of epidemiological modeling of late. And the presenter is Dr. Vergey, Stefan Vergey, who's the assistant professor of global health at the Harvard School of Public Health. He's in the Department of Global Health and Population. And so he comes from a multidisciplinary research focus on health decision science and priority setting. But he's particularly interested in looking at the impacts of non-health benefits, poverty alleviation benefits of health policies and interventions.
Activities. I would like to acknowledge, next slide, the funding from the Bill and This work was conducted in the context of the TB-MAC exercise and tries to quantify the poverty and equity benefits of TB control activities. I would like to acknowledge, next slide, the funding from the Bill and Melinda Gates Foundation, as well as the contributions of many from the TB-MAC exercise. Next slide. I'd like to start this presentation by positioning this work in the context of the post-2015 agenda and the discourse on poverty. Present economic evaluation tools and extended cost-effectiveness analysis, which we developed for health policy assessments. Apply these tools to TB control in South Africa and India, and conclude with a few remarks on how to anchor TB control activities within the poverty alleviation agenda post-2015. Next slide. Next slide. Most of you are very familiar with the discourse of poverty that we've been hearing over the last 15 years. Sustainable Development Goal 1 has the objective to end poverty in all its forms everywhere by 2030. In the meantime, the World Bank has been pushing two objectives: to eradicate extreme poverty, defined by living with less than $1.90 per day, to eradicate it by 2030, and to boost shared prosperity by raising the incomes of the bottom 40% of populations. Next slide. Indeed, there are good reasons to be optimistic if you look at trends in poverty over the number of people living under the poverty line over the last 25 years. From about 2 billion in 1990 to about 700 million in 2015. From about a third of the world population under the poverty line in 1990 to about 10% today. Next slide. That leads to aspirational objectives of poverty reduction by 2030, and these are projections over the next 15 years of what would be the number of poor in the world and in different world regions under different scenarios of growth rate. With the reasonable assumption of 4% income growth rate worldwide, 3% of the world population would be poor in 2030. Sub-Saharan Africa would still, though, concentrate a large number of this population of poor, with about 14% of its population being under the poverty line. In health, the link to poverty reduction or poverty is through financial risk protection. In the SDGs, SDG 3, the SDG goal for health is to achieve universal health coverage, including financial risk protection for all. In other words, the prevention of medical impoverishment of a provision or financial risk protection is the closest tie to poverty reduction that is defined in these goals. Next slide. Now, the big question that we face ahead of us is how to achieve the poverty objective by 2030. Now, the answers are a bit more vague that we keep hearing. Usual requirements are put forward: sustaining growth, investing in human development, developing social safety nets, and insuring against risks. But there's a lack of specific propositions and quantification of impact and cost. In other words, what the objective of the analyst might be is to quantify cost and impact of specific policies and interventions toward achieving these poverty reduction goals. Next slide. And that is what we are trying to do with developing new economic evaluation tools for health policy assessment. Next slide. In other words, the policy objective that we face, or the question that the analyst is facing, is to seek the efficient purchase of poverty reduction or financial risk protection in the health sector. In other words, if we have a defined set of policies, we would be interested in knowing how much it costs, as well as what is the return on investment in terms of poverty reduction or financial risk protection. In other words, per dollar spent per budget of, say, $10 million, we would be interested in knowing how many poverty cases would be averted, for example. In this context, next slide, we developed extended cost effectiveness analysis, or ECA, to conduct health policy assessment and to try to include the dimensions of equity and financial risk protection into economic evaluations for the health sector. We're interested in distributional consequences across distinct strata of population, socioeconomic status, geographical setting, gender, and financial risk protection to quantify household medical impoverishment averted by policy. Next slide. Now let us look at this in the context of TB control in two countries with very large TB burdens, India and South Africa. Next slide. The objective, and we conducted this in part of the TB-MAC exercise, is to estimate the poverty impact over the next 20 years in these two countries and examine three specific policies. Improved drug-sensitive TB care, which is tied to the improvement in quality, increasing treatment success rate, tied to financial incentives and improved nutrition to increase retention in care. Similarly, improved MDR-TB care, which is tied to the improvement in quality, increasing treatment success rate, tied to financial incentives and improved nutrition to increase retention in care. And then for South Africa only, looked at intensified case finding, which is that all individuals seeking health services would be screened for tuberculosis. Next slide. So how does the model work? We have modeling outputs from the TB-MAC exercise, TB cases, TB deaths. Then people are either on drug-sensitive TB treatment, MDR TB treatment, or face TB deaths. For each of these individuals and patients, we assign one household which has been given an annual income and specific patient cost. And the comparison between the patient cost and household income leads us to an estimate of incurred impoverishment. In other words, we count what we call catastrophic health costs when patient costs exceed 20% of household income. We assume also reasonably that individuals in poorer quintiles are more likely to have TB than individuals in richer quintiles, that conversely, individuals in richer quintiles are more likely to seek TB care than individuals in poorer quintiles. Next slide. We need a set of inputs for this. As I mentioned, the number of individuals in each country, that is on drug-sensitive TB care, MDR TB care, the number of deaths related to TB, and then relative risks according to each socioeconomic group of contracting TB as well as seeking health services for TB care. These gradients being influencing in terms of the outputs of catastrophic health cost, as we'll see in the coming slides. Next slide. In the meantime, we need obviously patient cost, both in the base case as well as once improved treatment policies have been in place, as well as funeral cost. And here is a list of inputs in terms of cost, unit costs that are used in these simulations. Likewise, we assume annual household income, which will be a comparator, and simulate income distributions in the two countries, India and South Africa, the repartition by income quintiles being given on this slide. Next slide. Now let us look at results for both India and South Africa. What we see here on these graphs are a display of the catastrophic health costs averted by the different policies. In India, improved drug-sensitive TB care, improved MDR TB care, that is in red, across different socioeconomic groups, that is on the left side, and then over time from 2016 to 2035. And what we see here is that the catastrophic health costs averted are very substantial, and that they are largely concentrated among the socioeconomic group 2 and 3, the second and third income quintiles, pretty much due to the fact that on the one hand, richer individuals seek more care than poor individuals, but poor individuals in the first place are actually contracting more TB disease than richer individuals. Now, let's move to South Africa, where we have 3 interventions. Again, the catastrophic health costs averted are very substantial, in particular intensified case finding, which, because it prevents ultimately down the line, as you can see on this very large growth on the right-hand side, a lot of secondary TB cases, eventually prevents a lot of catastrophic health costs or a number of impoverishment due to tuberculosis. These benefits are largely concentrated among the poorest socioeconomic group, and that is because the gradient of TB disease is largely concentrating among the poor in South Africa. The gradient of healthcare seeking is rather flatter, or much flatter in South Africa than India, and not so pro-rich in the end. And poor individuals obviously have much less purchasing power or income than richer individuals. Next slides. Now I would like to end up with a few concluding remarks, or how we can use this work in the terms of positioning or anchoring TB control within the discourse on poverty. Well, first of all, what we can do with extended cost effectiveness analysis is to highlight progressive prioritization. Here is an example of this, where you have poverty cases averted, deaths averted on the y-axis, the x-axis, for 9 interventions per $100,000 spent in Ethiopia, publicly financed. And what you see on this graph, circled in green, is the results for tuberculosis treatment. And you find that TB treatment would lead to a very large number of poverty cases averted per dollar spent. And in that sense, if you look at this two-dimensional graph would be bringing a lot of poverty reduction and would be, highly benefiting to the populations in this regard. Next slide. What I'm trying to make the point here is that within the health sector, if you use the same schematic of health benefits, poverty alleviation benefits per dollar spent, we've been focusing on high returns on health benefits for dollars spent, which is on the right-hand side of this figure. And whereas we won't be interested in the bottom left figure, which is low health benefits, low poverty alleviation benefits per dollar spent, we should be increasingly interested in looking for places where there's high poverty alleviation benefits. Perhaps even the places where, in spite of low health benefits, we could have high poverty alleviation benefits. And might be a place for investment for tuberculosis control, which is linked to the fact that tuberculosis impoverishes a vast number of people, and that remitting to this problem might lead to vast poverty reduction benefits. Next slide. But most importantly, what is very useful with anchoring health in terms of the poverty reduction agenda is that we can think about priority setting beyond the health sector. In other words, by estimating the efficient purchase of poverty alleviation benefits by health policies, say in poverty cases averted per $1 million invested, we are directly able to compare health policy investments with other sectors, education policy, transport policies, and are enabling the ministries of finance and development in low and middle income countries to make these intersectoral comparisons and ultimately increase the investments that are given to health sectors in these countries. Next slide. Thank you very much for your attention.
So I hope he could hear us wherever he is. So I think the one question now is whether, I don't know if there's anybody else in the room involved in the research. Some of us were tangentially in reviewing things, but I might look to Richard. I would say for those that have follow-up questions for the individuals who presented, they'll be here afterward, but maybe we can look to Richard unless Ted has a concluding comment he wants to make on the work. For Richard to talk a little bit about what the next step is with TB-MAC. Maybe we...
That sounds great.
I wasn't expecting that, but thank you, Diana. I thank you very much for coming. I think today's illustration of 5 very different, but in their way, all critically important contributions to TB control has been illustrated very, very well today, from poverty reduction to understanding fitness costs in TB, in drug-sensitive, drug-resistant TB. I think they're all critical contributions and nice illustrations of where the data runs out, where models can start to answer or explore some of these questions that we still have beyond the data. That's central to TB-MAC's core, and you heard from the beginning what TB-MAC's going to be about. We are refunded. You will start to see us gearing up in the next month or so, and we will be inviting you all to take part in our activities over the next 3 years. We very much look forward to working with you.
If I can say also that WHO's TB Impact Measurement Task Force is also going to be a place where TB-MAC can report back on some of its results with some of the other colleagues working in a broader space on this. So I think coalescing across the communities, and for those of us looking at these detailed models, I think coming up with the conclusion sides of, so what if, how is this model going to help us in the next step in either looking at future guidelines, you looking at future research opportunities, or looking at operational questions that countries and partners should be looking at. So I think for many of us, we look at models and we stand back and we say, oh, not my space, as Delia said. But I think the idea of creating a dialogue where even while some of these early research using modeling can say, well, what if, what next, among the community of researchers, but also the implementers. And we're very much thanks to the Gates Foundation, again, for the support for this and also for some of the support in utilizing that data at country level. Thank you very much.